and I'd like to welcome you to our first installment of our web conference series, Bundle Payment Best Practices. Today's conference is titled How to Prepare for the Comprehensive Care for Joint Replacement Model. My colleagues joining me today on today's panel are partners in the healthcare practice here at Foley and Lardner, Fred Galifas and Chris Donovan. Before we start, I would like to go over a few housekeeping tips. Today's program will run for 60 minutes. We will apply for 1 general CLE credit for today's program. For those of you interested in CLE, please listen carefully for the code that will be announced during today's broadcast. Once you hear the code, please enter it in the pop box that will appear on your screen. All New York, New Jersey, and Kansas attendees applying for CLE credit must also fill out an attorney affirmation form, which can be found in the resource list widget. Electronic questions can be submitted throughout the broadcast by clicking on the Q&A tab at the bottom of your screen. We will do our best to answer the questions at the end of the broadcast. If you would like a copy of the slides, it can be obtained in the resource widget. With that, we can proceed. Our agenda today is as follows. I will be providing an overview of the Comprehensive Care for Joint Replacement Model, which you'll hear referred to as a CJR or CJR. Chris will then address contracting with collaborators, and Fred will discuss compliance issues and implementing the model. We will then wrap up with a few practical considerations and next steps, and we'll take time to answer any questions that may come up at the end. With that, I will go ahead and get started. The Comprehensive Care for Joint Replacement Model was initially introduced by CMS in July of 2015, with the final rule being issued on November 16, 2015. According to CMS, the model aims to support better and more efficient care for beneficiaries undergoing the most common inpatient surgeries for Medicare, which are hip and knee replacements, and are also known as lower extremity joint replacements, or LEJRs, if you see that over the course of the hour. The model is intended first to test bundle payment and quality measurement for an episode of care associated with hip and knee replacements, and second, to encourage hospitals, physicians, and post-acute care providers to work together to improve the quality and coordination of care for beneficiaries from the initial hospitalization through to recovery. Hip and knee replacements are the most common inpatient surgery for Medicare beneficiaries and can require lengthy recovery and rehab periods. According to CMS, in 2014, there were more than 400,000 procedures costing more than $7 billion for the hospitalizations alone. However, there's significant variation among providers on cost and quality in these procedures. Unlike the BPCI, the CJR model requires mandatory participation of roughly 800 hospitals in 67 geographic areas. That said, any hospital in one of those areas that's participating in models 1, 2, or 4 of the BPCI for the lower extremity joint replacement episodes is excluded from participation. The model includes 5 performance years and kicks off on April 1st, 2016, just a few weeks away. The CJR was introduced in connection with CMS's goal to move the healthcare system towards value-based purchasing. CMS announced earlier this year its goal to have 30% of Medicare payments in alternative payment models by the end of 2016 and 50% by the end of 2018. Specifically, Medicare is looking to adopt alternative payment models built either on fee-for-service architecture, like this one is, or population-based payments. CMS has announced that this will be achieved through investment in alternative payment models, such as ACOs, advanced primary care medical homes, new models of bundling payments for episodes of care, and integrated care demonstrations for beneficiaries that are Medicare and Medicaid enrollees. CMS hopes that this model will result in better care for patients through coordinated high-quality care, smarter spending, resulting in healthier people and communities. Let's get into how the model works. The CJR model holds participant hospitals financially accountable for the quality and cost of the CJR episode of care, and is intended to incentivize increased coordination of care among hospitals, physicians, and post-acute care providers. Just to be clear, while collaboration is encouraged, the hospital is the entity that's on the hook. Chris will get into entering into agreements to encourage collaboration a little bit later, but ultimately, any risk that's associated with the model is the hospital's responsibility. A CJR episode is defined by the admission of an eligible Medicare fee-for-service beneficiary to a hospital that's eventually paid under the IPPS under a discharge for DRGs 469 or 470. Any individual who's covered under a managed care plan or commercial payer is excluded from the model. The episode of care continues for 90 days following discharge. Part A and Part B services relating to the episode are included in the episode. This includes physician services, inpatient hospitalizations, inpatient readmissions, long-term care hospital services, inpatient rehab, SNF services, home health, hospital outpatient services, outpatient therapy, clinical lab services, DME, Part B drugs and biologicals, and hospice care. The episode excludes acute clinical conditions not arising from complications of the LEJR surgery and chronic conditions that are generally not affected by the LEJR procedure and are unrelated. CMS has published a specified list of excluded DRGs and ICD diagnosis codes, which can be a resource in determining what's included or not included in the episode. For each performance year of this model, CMS will set target episode prices for each participant hospital that include payment for all of the related services furnished to a beneficiary who has an LEJR surgery at the hospital. All providers and suppliers will continue to be paid under their usual CMS fee-for-service payment system rules and the procedures of the Medicare program for episode services throughout the year. So everybody will continue to bill on a fee-for-service basis. Following the end of the performance year, actual spending for the episode will be compared to the Medicare episode target price for the hospital where the beneficiary had the surgery. Depending on the hospital's quality and episode spending performance, the hospital may receive an additional payment from Medicare or be required to pay Medicare for a portion of the episode spending. If a hospital achieves actual episode spending below the target price and achieves a minimum composite quality score, and I'll get to the quality piece in a second, it will be eligible to earn a reconciliation payment from Medicare for the difference between the target price and the actual episode spending, up to a specified cap. So there's a potential for upside. Similarly, in years 2 through 5 of the model, so beginning January 1st, 2017, if actual spending is above the target price, the hospital will be required to repay certain amounts to CMS. The first year, there's a potential for upside only and no risk, and upside only is capped at 5%. In performance year 2, which will begin January 1st, 2017, the potential upside is capped at 5% of the target, and downside is capped at 5%. In performance year 3, which will begin January 1st, 2018, potential upside is capped at 10%, and downside is capped at 10%. And in performance years 4 and 5, which begin January 1st, 2019, potential upside is capped at 20%, and downside is capped at 20%. So as the ability for sharing and gain increases, so does the potential risk. Each hospital will have its own target prices, and they'll have separate target prices for DRGs under 469 and 470, which will reflect the differences in spending for each episode. The model is a retrospective bundled payment model that will be based on prior performance. CMS will provide participant hospitals with target prices before the start of each performance year. Episode targets will be established based initially on a mix of both hospital-specific and regional historic spending, but over the course of the model, so over the 5 years, will transition to eventually being a regional target. Regions are defined using the 9 U.S. Census Division region definitions, and CMS will use the most recent 3 years of available data for establishing the baseline for each performance year. In addition, CMS will apply an automatic discount to the episode target cost of care. The discount percentage will vary somewhere between 1.5 and 3% based upon the hospital's quality score. To help hospitals manage the risk associated with certain exceptionally costly cases, CMS is going to apply a high episode payment ceiling when it's calculating actual episode payments, when it sets episode target prices, and when it calculates reconciliation and repayment amounts. CMS has also adopted an appeals process through which CJR participant hospitals can contest various payment and reconciliation calculations as the model progresses. CMS is going to assign each hospital a quality composite score based on 3 quality measures and how the hospital ranks on the program's quality measures relative to everybody else. Two of those measures will be the most significant impact, with the third measure just being self-reported and just a small percentage. The quality composite score will be on a scale of 0 to 20, and each measure will have a different contribution to the overall score. And each hospital will earn points determined based on its relative performance within the quality measures. Where a hospital ranks relative to other hospitals will determine how many points are achieved for each quality measure. The quality composite score will impact a hospital's payment in two ways. First, if the composite score is below acceptable, the hospital will not be able to receive any reconciliation payments, regardless of their performance on cost measures. Second, the composite score will determine the effective discount percent for both reconciliation payments and repayment. If a hospital performs very well on the quality composite score, the discount percent for the episode target price will be reduced to 1.5%. However, if a hospital does poorly, the effective discount will be 3%. This interaction creates an added financial incentive for hospitals to focus on quality performance and improvement. The model also includes 3 programmatic waivers that waive certain payment system requirements in order to assist hospitals to provide care in a more efficient, convenient setting, and to encourage timely, accessible care and facilitate improved communication and treatment adherence. These include a waiver of the 3-day rule for SNF admission, allowing for certain payment for certain physician visits to a beneficiary in his or her home via telehealth, and allowing payment for certain types of physician-directed home visits for non-homebound beneficiaries. So the first waiver, or programmatic waiver, we'll get into fraud and abuse waivers a little later, is the waiver of the 3-day SNF rule, and it applies beginning in performance year 2. CMS will waive the 3-day rule for SNF coverage following an anchor hospitalization, but only if the chosen SNF is identified in a list of qualified SNFs at the time of admission. Qualification is based on star rating. A SNF must have been rated 3 stars or better for at least 7 of the last 12 months, and the list will be updated quarterly. And despite the waiver, CMS has emphasized that beneficiaries must not be discharged prematurely to SNFs, and they must be able to exercise their freedom of choice without patient steering. The second programmatic waiver allows for home visits, for post-discharge home visits. CMS waives the incident to direct supervision rule for physician services. This allows clinical staff of a physician or non-physician practitioner to visit in the beneficiary's home under the general supervision of a physician after an anchor admission, and to be able to bill for that, even though it was not under direct supervision as required by Incident 2. The visit has to be in the beneficiary's home or place of residence. It must be by clinical staff generally supervised by the physician, and it's permitted only for beneficiaries who do not qualify for Medicare coverage of home health services. So if a beneficiary is actually homebound and could receive home health, it would have to receive services through home health and not from their physician. The waiver allows for a maximum of 9 visits during the episode, and is built into the physician fee schedule using a HCFS code created specifically for the model. And finally, there's a telehealth waiver, which allows for expanded access to telehealth services paid for under Medicare. Medicare currently pays for telehealth services furnished by a physician or practitioner, even though the physician or practitioner is not in the same location as a beneficiary, but such payment is subject to a specific geographic site and originating site requirements, among others. The final rule for the CJR waives the geographic site requirements that limit telehealth payment to services furnished within specific types of geographic areas or in an entity participating in a federal telemedicine demonstration project. All services that are Medicare-approved telehealth services and reported on a claim with an ICD-10 diagnosis code not excluded from the CJR episode can be furnished to a beneficiary regardless of geographic location. Additionally, the CJR waives the originating site requirements that specify the particular sites at which the eligible telehealth individual must be located at the same time as service is furnished via telecommunication system. So you eliminate that requirement. Even though CMS is waiving the geographic site and originating site requirements, it will not permit additional payment to be made to cover setup costs, technology purchases, training and education, or other related costs. The facility fee paid by Medicare to an originating site for telehealth services will be waived if the service is originated in the beneficiary's home. All other current requirements for Medicare coverage and payment of telehealth services not waived by the final rule will continue to apply, including the list of services approved to be furnished by telehealth. And lastly, before I pass this on to Chris, I just wanted to touch on data sharing. In order to help hospitals be successful in this model, CMS is going to be making data available to all participant hospitals. This includes individual beneficiary Part A and Part B claims for the duration of an episode and aggregate regional claims data. It can be provided, I believe, as often as the hospital requests it, and at least quarterly. CMS, just in case anybody has not done this already, has asked that each hospital provide contact points for each hospital in order to begin the coordination of the provision of data. So if anybody has not done that already, it should go ahead and do so. With that, I'll turn this over to Chris Donovan, who will walk us through the requirements for contracting with providers under the model.
Thank you, Alexis, and congratulations, you ended just promptly on time. I'm going to talk about sharing arrangements with collaborators, and anybody that's dealt with bundled payments probably in the Bundled Payment Care Initiative program probably recognizes that terminology in some of these programs can be really arcane. I think that the good news about the CJR program is actually the terminology is pretty straightforward compared to other BP programs. We have conveners and awardees and other types of terminology. So I would say, just sort of off the top, the regulations are pretty straightforward. They do allow risk sharing. I think where the interesting part of this whole arrangement is going to come in, and we're going to talk about it at the end of our presentation after Fred's discussion of the waivers, is the actual negotiation of some of these collaboration agreements. But let me give you an overview of what the regulations say about risk sharing agreements. So as Alexis pointed out, it's really the hospital that is the hub and spokes to this model. The hospital is the entity that is is at risk effectively under these two DRGs for hip and knee replacement. What they can do is they can enter into what is referred to in the regulations as sharing agreements with collaborators. Collaborators can be any of the physician group practice, or post-acute care providers and suppliers that Alexis previously mentioned. And these agreements are referred to as sharing agreements, and they allow for either gain sharing of the upside that the hospital achieves through achieving costs below the target, or alternatively making what is referred to in the regulations as an alignment payment. That is a payment from the hospital or the collaborators to the hospital and then in turn to CMS because the costs have exceeded the target episode cost. But initially, the hospital has ultimate liability. I'll talk a little bit in the next slide or two about how they can share and the restrictions on how much of that risk they can share with others. There are 3 or 4 key terms in the sharing agreements that have to be included, one of which is the quality criteria that have to be identified in order for the collaborator to either receive or not receive gain-sharing payments from the hospital. So the one thing about this set of regulations that's pretty interesting and I think is going to invite some discussion and perhaps creativity and alternative models is the criteria really are not identified in the regulations. It's up to the hospital and the collaborators to define the quality criteria. We were talking a little bit earlier. That might be initially something like the criteria that's used in connection with the nursing home or the home health compare 5-star criteria, which sort of ties into the minimum requirements that the hospitals have to abide by in terms of selecting post-acute preferred providers. It may be other criteria, but those are all negotiable between the hospital and the collaborators. The point is that they have to be identified in the agreement, and the methodology by which the collaborator either achieves those metrics or fails to achieve those have to be identified specifically as well in the agreement. Next, collaborators have to contribute to the hospital's care redesign. and there needs to be a discussion of that in the Collaborator agreement with respect to the ability of the hospital to redesign its care system for these kinds of procedures. And the relevance of that is that the source of gain sharing is really two sources under these contracts. One is the gain sharing money that's attributed from CMS in connection with achieving a target cost of these episodes below the target. And the other is that gain sharing payments can be achieved from reductions in internal hospital costs, which have to be carefully documented, and I'll get into that in a second. But the idea behind the care redesign obligation and the Collaborator agreements is it dovetails into the ability of hospitals to pay gain sharers actual internal hospital cost savings achieved as a result of the care redesign in which the collaborators are participating. As Alexis said before, the episode starts with admission to an acute care setting and ends 90 days after discharge. So it obviously includes, the full spectrum of post-acute care, and I won't go into that. I think Alexis gave an exhaustive list of what those services would be. All services in the episode effectively are attributed to the hospital, and absent any risk sharing, which I suppose would be unlikely, the hospital would still, bear the burden of any downside. As Alexis indicated, the providers who are the collaborators do continue to bill fee-for-service, much like other bundle payments. And again, a description of the gain sharing, the alignment payment, the quality criteria, and methodology for those payments all have to be spelled out. One area that has to be included in the Collaborator agreement are safeguards regarding patient choice and care stinting. And sort of interesting in the regulations when you read them as a whole. In one section, the regulations require the Collaborator agreements to have these safeguards, but in another section, which I'll get to in a second, dealing with the hospital discharge planning, it allows the hospitals to refer patients to so-called preferred providers consistent with applicable law. And for those hospitals out there that are now looking at the notice of program rulemaking for the new hospital discharge rules, which require pretty much a total overhaul in the hospital's discharging process, and including patient preferences, et cetera. I think this area of patient choice and the intersection of this patient choice requirement, which of course is a requirement of the COPs, is going to run to some extent directly against the quality metrics that the program is trying to drive and achieve. So there's in my opinion, some pretty wide berth between what the regulations are requiring here in terms of safeguards and the contracts. Conversely, and I'll get to it in a second, with the ability of hospitals to select preferred providers and to indicate which providers are preferred providers. My sense is that what will be required here is that hospitals, for example, in the case of home health, will need to give appropriate home health choices in a geographic market to respect patient choice, but through quality metrics and other information that is objective that they have, we'll be able to designate preferred providers, presumably the ones that are collaborators with them in the CJR program. So that's I think an important and sensitive area to this, and I think for all the post-acute providers, one to pay attention to. Again, internal cost savings have to be verified based on care design, and finally, there has to be a web listing on the hospital's website of all of their collaborators, sort of similar to what I think people see in the ACO program with the waivers required for the fraud and abuse waivers. Under the ACO final waivers, there's a requirement to at least put a web listing of the relationship, and that's, I think, similar to what's happening here. So let's talk a little about, Alexis did a nice job sort of talking about how the hospital has stop loss and gain loss gains on the payments coming from CMS or going to CMS in the form of reconciliation payments and alignment payments from the hospital. This slide deals with the floors and caps associated with the agreements between the hospital and the collaborators. So what the regulations say is that in any calendar year, total alignment payments, and again, those are payments by the collaborator to the hospital, can't exceed 50% of the hospital repayment amounts to CMS. In plain English, the hospital has to keep 50% of the downside. What the regulations do allow, however, is for the hospital to delegate, push the other 50% of that downside. When I mean downside, I mean the delta between the actual episode costs and the target costs, assuming there is a downside and not an upside. The hospital can take that other 50% and push it down to the collaborators, but it can't push more than 25% of that other 50% to a single collaborator. So the idea here is, I think, just to spread that risk and to sort of align people along a care redesign program so that not any one collaborator is responsible for the other 50% of the downside risk that the hospital did not retain. Replete through all these regulations, of course, are requirements that none of the gain sharing or reconciliation payments be tied to the volume or value of referrals, but they have to be tied to quality of care and metrics agreed to up front. The other, flipping the paradigm a little bit, getting away from downside and talking about upside, the regulations also cap the gain sharing payment that can be paid to physician group practices or physicians to 50% of the amount that would have been billed under the physician fee schedule. So there's no ceiling on gain sharing payments to, let's just say, post-acute providers, but there is a 50% cap on gain sharing payments to PGPs equal to an amount above 50% that would have been billed under the PFS, absent the bundled payment arrangement. And then finally, again, an additional source of gain sharing may be internal cost savings. The hospital realizes they have to be actual, verifiable, not paper savings realized from care redesign undertaken by the hospital in conjunction with the collaborators, and they have to be realized by the hospital and not by the collaborator. I said off the top the terminology was relatively more straightforward than the Bundled Payment Care Initiative program. One deviation from that is there's a reference in the regulations to distribution agreements. Distribution agreements really are gain sharing or collaborator agreements between a PGP collaborator and what's referred to as a practice collaboration agent, pursuant to which the PGP distributes gain share from the hospital. It's limited to share payments with physicians who treated CJR beneficiaries in the episode. The practice collaboration agent must be a PGP member who has entered into a distribution agreement with the same PGP. So this is really more of not a structural or substantive change, just really a terminology nuance that these regulations introduced in the cases of PGPs. Reconnecting this to my earlier comments about discharges from hospitals, there's quite a bit of discussion about beneficiary choice and notification to beneficiaries of possible collaborators. It's clear in the regulations that beneficiaries always have the ability to choose a provider after discharge, including one that's not a collaborator with the hospital, which I think is one of the challenges of any BP program. We'll talk about that at the end. The hospital has to notify the beneficiary of all post-acute care providers in the area and disclose those of whom who are collaborators with the hospital and with whom the hospital has a financial relationship, much like the existing COPs, for example, in the case of home health. And interestingly, the hospitals can recommend preferred providers consistent with applicable law. The regulations don't really tease that out in terms of exactly what that means. I think our interpretation of that would probably mean what I said earlier, that consistent with providing, for example, a geographic list of appropriate providers, for example, in the area that would be capable of servicing the patient, for example, on post-acute. The hospital can also include quality criteria that it's used to include that provider in its in its network as a collaborator and indicate that to the beneficiary, to the patient, obviously allowing them to choose, but making sure that they saw or what the hospital considered to be criteria that favored one provider versus others with less with lower scores on the quality metrics. Next point, the regulations prohibit hospitals from charging a preferred provider fee. Sometimes we see this in the case of ACOs, where ACOs are charging, fees for connections, for software connections and other, administrative fees and other fees that sometimes are nominal and sometimes aren't, but are designed to basically get at, connecting, creating care coordination. But in the case of the CJR BP, hospitals cannot charge any kind of fee that would, be a condition to being a preferred provider under the network, essentially. Talking a little bit about, there are requirements in the regulations as to what hospitals have to do to include a collaborator in their preferred network. They have to have a written agreement. The hospital has to develop a written set of policies for selecting providers and suppliers. The criteria have to be based on quality, not volume or value of referrals. In the case of PGPs, they must contribute to care redesign and be clinically involved in CJR beneficiaries' care. Most importantly, these agreements have to tie to the overall hospital's corporate compliance plan, and I think the regulations anticipate that the CJR BP will be woven into and included in the hospital's corporate compliance plan with respect to the programmatic waivers and the fraud and abuse waivers that Fred is going to talk about in a second, as well as the requirements for selecting and paying collaborators and documenting collaboration agreements. Finally, it's one of the interesting things apart, I think, for us, and I think one of the interesting things to see how this is all going to play out is, subject to the caps and floors that I mentioned earlier about the hospital retaining 50% of the downside and capping PGP payments at 50% of the physician fee schedule, there's quite a bit of latitude on the part of the hospital to allocate upside and downside between various post-acute providers and physicians. The regulations allow that flexibility subject to the caps that I previously indicated. So I think one of the issues we see will be, it'll be interesting to see, where these arrangements shake out in terms of risk sharing and what strategies the parties will develop in terms of being able to align various parties and motivate certain various parties. And as I said, we're going to talk about that at the end on the practical slide I'll get to in a second. So right now I think I'm going to turn it over to my partner, Fred Galfus, and he's going to talk a little bit about fraud and abuse waivers, and then we're going to move to some practical observations at the back end. Fred?
Thank you very much, Chris. And as will come as no surprise in healthcare, there are a variety of compliance issues that are related to bundled payments and the CJR model program. As we've put together and structured bundled payments over the years, there are a variety of kind of unique compliance challenges that relate to bundled payments. Typically, they involve sharing payments from a hospital to others that are involved in the care of the patient in the bundle. How do you select who those participants are? Can create some issues. You have to avoid selecting them based on the volume and value of their services to the hospital. You also want to encourage use of the participants, the people that have agreed to participate, if they're going to engage in care redesign and the like. So the steerage rules are also compliance creating issue. You're also worried about incentive payments in how you would structure care so that people would reduce the care that they provide, which runs into the CMP gain sharing law. There's also a desire to the extent infrastructure and shared data is necessary, to share that and to share the expense of that. You also want to encourage beneficiaries so that they'll adhere to the care plans and do the things necessary to take out the discretionary costs and make sure that only actual necessary costs are incurred. And there's an incentive to avoid expensive cases. Now, many of these apply as we would expect in the CJR program, as well as in the normal bundle payment programs that we've worked in structuring over the years. Although the structure of this bundled payment initiative is a little bit different. As has been explained, there really is no bundled payment that's made as such. Everybody builds fee for service, and it's an accounting method, a target against some repayment obligations that really drive the program. So it's a little bit different, but still some of the same issues apply. And in the regulations, CMS and OIG were well aware of a variety of the compliance-type issues to be cognizant of, and the regs really go through them in specificity. First of all, it's a compliant challenge and a requirement to comply with all the requirements of the regulations. That includes all of the things that Alexis and Chris walked through, the collaborator agreements, the sharing agreements that Chris talked about, all have specific requirements that have to be included in them, and you need to be compliant with those all the way along the line. But there also is a portion of the regulations that say CMS and OIG will monitor a variety of issues, some of which we're kind of used to and being aware of in the bundled payment programs that we've structured over the years, avoiding potentially high-cost patients. They want to make sure that doesn't happen. They want to make sure participant hospitals don't target potentially low-cost patients. They want to make sure that medically appropriate services are provided and that nobody engages in the over or under delivery of appropriate care. They're going to monitor failing to provide beneficiaries with complete and accurate information, and they spell out in the regulations some notices that are required to be given to the beneficiaries about their participation in the program and some other things. They're failing to allow beneficiary choice of medically necessary options. As with most of the value-based programs we've seen, the ACO program, the Medicare Shared Savings Program, beneficiary choice remains sacrosanct, and it is as well in the bundled payment program. Failing to follow the requirements of the collaborator agreement is also something they're going to monitor. Signing a collaborator agreement that doesn't comply with the requirements, and that can add conditions and the like, it can also be problematic and will be monitored. Taking any action that threatens the health or safety of a patient, avoiding at-risk beneficiaries, becoming subject to sanctions and fraud actions. These are all things that CMS and OIG are going to look at throughout. The next one I find a little bit interesting, that taking any action that CMS determines for program integrity reasons is not in the best interest of the CJR model. Will be a compliance issue that CMS is targeted with reviewing. So there's some discretion in that. If they decide they see some behavior or there was a loophole in the regs that some providers start taking advantage of, CMS and OIG have some ability to come back and monitor those and provide some remedial actions. Again, and these last two are also involved. You can't be involved in a violation of Stark CMP related to laws relevant to the CJR. If CMS or OIG finds this, the regulations spell out some of the permitted, what CMS may do as remedial actions. They can provide a warning letter, establish a correction action plan. They can reduce or eliminate the reconciliation payment if they find bad behavior amongst the items we talked about. They can require termination of the collaborator agreement. And in certain circumstances that are spelled out, CMS may also require an additional 25% repayment amount to be made from the hospital. So instead of paying back the difference between the target and the actual cost, they may add 25% to that. But we do have some waivers. We have 3 fraud and abuse waivers that are proposed. They are, for those familiar with the fraud and abuse waivers under the Medicare Shared Savings Program, you'll see that they're quite a bit more limited. Under the Shared Savings Program, a key aspect was whether the financial arrangement that was involved furthered the purposes of the Medicare Shared Savings Program, and if it did, there was a lot of flexibility to move ahead. That is not the case with respect to these waivers. They're much more specific. There can be no infrastructure or technology sharing in the waivers. There are no return on investment payment ability to waive those kinds of programs. Also, for increased transparency in the first 2 waivers, payments have to be made by electronic funds transfers, and they cannot be in-kind contributions. They have to be cash contributions in the first 2 waivers. In the third waiver, they can only be in-kind contributions, as we'll see. And as we would expect, they only waive specific laws that are specifically cited with respect to the waivers. So there are 3 waivers. The first is a waiver for distribution of gain sharing payments and payment for alignment payments under this sharing arrangement. Call this the gain sharing and alignment payment waiver. There's also a waiver for distribution payments from the physician group practice to a practice collaboration agent, which I shorthand is the employees of the group practice or contractors of the group practice. So the distributions from the PGP to the participants in the group practice can also be subject to a waiver. And finally, they permit waiver of patient engagement incentives that are provided by the participant hospitals to beneficiaries. The first waiver, again, it protects only the sharing of distribution of gain sharing payments and payment of alignment payments under a sharing arrangement. It waives the federal Stark and anti-kickback liability. As with other waivers we've seen, there's no state law waiver from state law violations. So you need to be cognizant of what state you're in and what the state analogs are to the federal statutes. Again, the payments must be by electronic funds transfer, and there can be no in-kind payments in the first waiver. There are 6 requirements which must be met. The first is your contract must meet the requirements of the regulations cited here. Among those are that the sharing agreement arrangement meets all the requirements. The hospital is required to update its compliance plan for the sharing arrangement. The hospital has to have policies in place to select providers and suppliers of the collaborators. It also is a requirement to absolutely meet the beneficiary choice, the freedom of choice, and the beneficiary notice requirements to qualify for the waivers. Interestingly, the hospital may not add conditions, limitations, or restrictions, other than those required or permitted in the CJR rule. You can't add conditions. I think they're worried about creative conditions that will say that really are aimed at ensuring behavior outside of the CJR episode are involved. But I think that's an interesting one that you cannot. Your collaborator agreement really has to be pretty much the specified collaborator agreement within some parameters. The criteria for selecting suppliers must include criteria related to quality to be delivered during the episode. They don't really say a lot about how you use quality here. Chris went into this issue a little bit, and it's an interesting issue and something I think there's a little bit of discretion on how you use quality. And the collaborator must meet those quality criteria for the calendar year, and the quality criteria have to be related to the episode and be in the sharing agreement. And the methodology for determining the gain sharing payment to be made to the collaborator must at least in part be based on those criteria. The second waiver, again, is the physician group practice to the collaboration agent waiver, and this protects distribution payments from the physician group practice that is a collaborator. So they receive payments, the payments the physician group practice receives from the hub hospital, if you will, can be passed on to collaborator agents who are entitled to receive distributions under this regulation. This waiver waives the federal Stark and anti-kickback liability issue again. Again, no state limitation. Curiously, it doesn't apply to payments of alignment payments. This is if a collaboration agent is required to participate in the downside and pay back to the physician group practice a portion of that payment. It occurs to me that the reason for I initially thought that was just an oversight when I saw that, but it occurs to me that there's very little risk in those payments if the collaboration agent is repaying the distribution distribution payment or being obligated to repay some of the amounts back to the hospital. There are also 5 requirements in this waiver. You need to meet the requirements for what distribution agreements provide. The distribution payments can come solely from gain sharing payments by a hospital to the physician group practice. You have to satisfy all the requirements from the hospital to the PGP must be satisfied. The distribution payments have to be made pursuant to a written distribution arrangement that meet the terms of the regulations. And as we saw in the prior waiver, the physician group practice may not add conditions, limitations, or restrictions other than those required by the rule. The third waiver is different in kind. It permits benefits to be provided to beneficiaries in connection with an episode. Here you cannot provide cash, you can't provide gift cards, coupons, or cash equivalents. And this is a waiver of both the beneficiary inducement CMP law and the federal anti-kickback statute. And there are 7 requirements to meet this. The item or service must be provided directly by the hospital or an agent of the hospital to the beneficiary. The item or service must be provided in kind. There can be no cash included, as we saw in the previous slide. The service or item has to be provided during the course of the episode and can't be provided after the fact. The item or service must be reasonably connected to one of the stated purposes. It either has to be for preventative care or it has to advance one of the following goals. So adherence to a drug regime, adherence to a care plan, reduction of readmissions or complications, and management of chronic diseases that may be affected by the CJR. Again, the item or service cannot be tied to receipt of items or services outside of the episode, and all the requirements for documentation. There is a requirement to document the beneficiary incentives that are provided. They all have to be met. There also are limits in the regulations as to the amount of certain kinds of items and services that may be provided, the value of them. If it involves technology transfers, it can't exceed $1,000 in retail value, and if it's 100 or more, the hospital must continue to own the technology that's involved. So those are the patient engagement ones. When you think of what patient engagement waivers really are talking about, I think they're talking about transportation, free transportation to get back to appointments, providing monitors that permit monitoring of conditions that would require further care. We also have seen talk about a variety of, it's on this slide as well, an enhanced role for hospitalists and SNFists to stay in touch with the patient after after the episode is concluded, so that if problems arise, they can be noted quickly and attended to quickly. I think as we think about these, it's one thing to understand the regulations, and it's a second thing to really develop strategic approaches that may work for your organization as you move into the CJR model. Whether you're the hub hospital, physicians that are involved in the episode, or post-acute providers, I think you're all going to want to have different strategies and thought processes as you approach the CJR. As Chris had gone through, it dovetails nicely with the recent PRM on hospital and discharge processes that's been redone. Discharge planning will be critical in engaging post-acute providers by hospitals, and post-acute providers can really bring value to these. I think it's been suggested that one of the largest variants in geographic variation on the DRGs that are covered by this is really in the post-acute arena. So this may be an area that is low-lying fruit for cost savings. And again, the increased role for hospitalists and SNFists, physicians and nurses that follow patients into the nursing homes, as well as hospitalists to keep in touch with the patient and highlight issues that can come up quickly. Other issues, there'll obviously be a need to invest in care coordination personnel, infrastructure, but they cannot include the ACO style infrastructure because we don't have those kind of waivers in this program. There also are some opportunities and challenges to identify possible outliers in episode early on, so that you can plan post-discharge care. How do you deal with those outliers that are going to be there? Patient leakage may be another issue where subsequent care is provided by non-collaborators, but by different hospitals. You know, I live in Wisconsin, and you could imagine somebody has a replacement surgery and decides to go to Florida for the recovery, and if they need hospitalizations after that, they may not go back to the same hospital. They could go to a different hospital, and if it's in the first 90 days, those costs will still count. So accounting for that leakage and how you deal with it will be a challenge and something you're going to want to think significantly about. Finally, what are practical considerations as you approach collaborator negotiations? The hospital, under the regs, is the one responsible. They receive the whole upside and the whole downside, although they can enter sharing agreements that push some of these, either the upside or the downside, to others, subject to the limits that Chris walked through. What is the strategy for approaching physicians, post-acute providers, home care agencies, SNFs, you name the hospices, you name I guess hospice shouldn't be involved very much, but approaching others to share either an upside or downside. And will the post-acute providers, will they see it appropriate to come up with policies and procedures as to what they will accept, what they should accept, what the role of quality should be, what they can monitor, what they feel they can be responsible for? Those would be obviously strategic considerations that both hospitals and post-acute providers are going to want to think through in detail.
Fred, if I could just interrupt Chris Donovan, and just to follow up on that point, I mean, we were talking earlier about what some of the payment methodologies would be under some of these contracts, and we got a call from, or there was a question online here from somebody who operates a critical access hospital, and she was saying that they don't have 5-star ratings, and I don't think IRFs do, and LTACs don't, and I think one of the big questions here are going to be, from the hospital standpoint, and they're putting a network together, how do they put that network together where you don't have, the 5-star rating system, for example, that's applicable to SNFs and home health. What kind of quality metrics are you going to be looking for? And in return, even within home health and nursing homes, for example, where you do have nursing home compare, some of the metrics on those star ratings, for example, readmissions, et cetera, I can see being appropriate, but some of them aren't necessarily. The use of psychotropic drugs, that you're dealing with broader categories of quality that are not directly tied to a CJR episode, for example. So I think the as you were saying earlier, Fred, these regulations appear to me to be more enabling in nature, and how hospitals partner up with PGPs and PACs to come up with an episodic coordinated care module for this, and what the metrics are going to be for how upside and downside is shared, I think really is what we're about to get into. I think the good news is the government doesn't seem to want to, subject to the caps, callers, and patient choice, and even then I think is letting people put some thumb on the scale with respect to preferred providers. There's a lot of flexibility in the regulations as to how that's going to get done. So I just wanted to mention, Fred, from the Q&A log on the computer here, there are people wondering about how they satisfy these quality criteria where there are no sort of government-ready quality criteria, now available, as is the case for certain providers like home health and hospice. And somebody else asked the question of, where is the contracting going to be driven from, the hospitals or from, the Collaborator side? And I'm 90% sure it will come from the hospital side because, as you mentioned, it's going to be their responsibility. And I'm thinking that they're going to want their agreements with their collaboration team, whether it's a PGP or a home health or an LTAC or whatever, to really harmonize with each other. And there may be common components to these various contracts for care coordination that they're going to want to see consistent throughout. So I'd be surprised if the contracting process for this isn't kicked off, initiated, and frankly controlled by the hospitals.
You would think that, although you may see some post-acute providers who view this as a real opportunity to become close to a hospital and to say we really have some value to add, to come to a hospital with a model that works as well. But I agree with you. Yep. The hospital will be the driver of the start of the negotiations. And a lot of these issues that we've listed here on the last 3 pages are issues that we will be exploring in additional webinars over the course of the next couple months. We've partnered with some others that have been working in the field, and we're not in a position to make announcements yet as to the timing on those, but keep an eye out for them, because I think we'll be able to come back and really focus on these practical issues and how you can really help your organization as you do that. We're almost up against the hour. Want to see if there are any additional questions. Have we got any other additional questions we should address? And
Fred, before we get to those additional questions, I just wanted to take a second for anybody who's looking for CLE credit. The code for CLE, which you can enter in your screen now, is 5, X like X-ray, D like dog, M like Michael, I like igloo. That's 5, the number 5, X like X-ray, D like dog, M like Michael, I like igloo. I'll say it one more time, and then we have about 1 minute or so to answer any more questions. So that's 5, X like X-ray, D like dog, M like Michael, I like igloo.
Thanks, Alexis. It looks like we have a number of questions. I think we're going to run out of time to address them all, but we do have, I believe we have ability to get back in touch with you, and we'll endeavor to do so offline. And I'm sorry we didn't have more time. I think as you think about this CJR program, you really are struck with lots of questions on how you can make it work, as well as the details of what's required. And again, we will be holding additional webinars. I think they'll focus more on the strategy and the opportunities that are presented. But again, I apologize for not having time to get back to the questions we weren't able to get to. But we will do our best to reach out to you, and we invite you to reach out to us as well. And we have the emails or phones here that please feel free to call any of us, and we'll do our best to answer your question as promptly as we can. But I'd really like to thank you all for participating, and look forward to and hope you can join our future series on this new program. Thanks very much.